Good afternoon. So, welcome all. On behalf of NMC Abu Dhabi, I express my pleasure to welcome you all for our 8th edition of International Conference on Gastroenterology and Therapeutic GI Endoscopy. Our conference is a trusted platform for sharing the knowledge from people all over the world, and we have had the opportunity to network and exchange with colleagues over a period of many years. The speakers, we have lined up excellent speakers for you who are experts in their field. So they will take you to your journey to the gastroenterology, therapeutic endoscopy, to the realms of gastroenterology. So our program is divided into 2 days. So we are having the first session in which most of the international speakers will be on the Zoom, except for the evening session. We'll have a live endoscopy EUS course, which will be relayed from 6 to 7, our local time here, from reputed center in Pune. And after that, we'll have a last session with our international speakers, and we'll end at around 8:30 today. And tomorrow we are starting early at 8:30, and we will have, including luncheon session, we'll have the program till 5 p.m. So for the first session, I will invite our chairpersons. So Dr. George Zakaria, Dr. Prakash Shankar, and Dr. Arun Kora and Dr. Amal Upadhyay. So Dr. George is a specialist gastroenterology working with Ahliya Hospital, Musaffa. He has been trained in India, and his special interests are medical gastroenterology and general medical GI procedures. Dr. Prakash is our gastro colleague from Align, NMC, and he has been practicing gastroenterology and therapeutic GI endoscopy for past 10 years. And he has special interest in therapeutic endoscopy and ERCPs. Dr. Arun, my colleague at NMC Specialty Abu Dhabi, and he is practicing for more than 15 years. His area of interest is diagnostic therapeutic endoscopy, including manometry and motility studies. Dr. Amol is a senior consultant at Aster Medical Hospital, Mankul. He is a member of Royal College of Physicians, UK, and he is an expert in ERCP and therapeutic GI procedures. So I'll ask them to take ahead the proceedings from here. Thank you.
Good afternoon. It is a great pleasure to start the next session, and the first talk will be
today we will be starting our academic activities with Professor Bronte Holt, who is the Director of Endoscopy at Melbourne in Australia. The first topic of presentation is cold snare polypectomy. How far can it go? Now, regarding Dr. Bronte Holt, she is an interventional gastroenterologist at St. Vincent's Hospital and a senior clinical fellow at University of Melbourne. Dr. Holt commenced an endoscopy fellowship at Westmead Hospital, University of Sydney. She did her fellowship in interventional endoscopy at Florida, United States of America, with Dr. Shyam Varadarajalu. Bronte's endoscopic interests include diagnostic and interventional endoscopic ultrasonography, pancreatic and biliary ERCP, advanced resections, including peroral endoscopic myotomy, submucosal dissections. She also manages complicated inflammatory bowel diseases, including research as well as teaching. So we can start off with the topic. I welcome Professor Bronte Holt to start off with the topic.
Hello, my name is Bronte Holt, and I'm from St. Vincent's Hospital in Melbourne, Australia, and the University of Melbourne. Today I'm talking on cold snare polypectomy. How far can it go? I'd like to thank the conference organisers for asking me to talk today, and I have no disclosures. A careful assessment of any lesion before resection is vital because it informs on the risk of submucosal invasion, the presence of submucosal scarring, and endoscopic accessibility. Cold snare resection is used for lesions located in the mucosal layer only, so looking at the morphology, size, and location of the lesion can help inform on the possibility that cold snare resection may be safe and effective. With the morphology, we use the Paris classification system. Lesions that are non-granular have a higher risk of more advanced pathology, as do larger polyp sizes or a larger nodule within the polyp. The location is also important, as lesions more distally towards the rectum have higher risk of more advanced pathology than more proximal colonic lesions. The Paris classification system divides lesions into protruded lesions, which have the P or S subtype, flat elevated lesions, or flat lesions. Lesions that have a depressed component, which is a C or a 3 type lesions, or are more elevated, such as the 0,1S lesions, have a higher risk of more advanced pathology. Next follows a close-up interrogation of the lesion with high-definition white light and narrowband imaging, looking at the pit pattern and vascularity of the lesion. Narrowband imaging helps define the capillary pattern within a lesion, and the JNET, or Japan NBI Expert Team Classification System, was proposed in 2014 as a universal NBI magnifying endoscopic classification system for colorectal tumours. This divides polyp types into 4 types, type 1 being a hyperplastic or sessile serrated polyps, types 2A and 2B being adenomatous polyps, dividing these into those that are most likely to be low-grade lesions versus high-grade or shallow submucosal invasive lesions, and type 3 being those with deep submucosal invasive cancer. Once a lesion has been established to be at low risk of having submucosal invasion, then the decision is on how to resect the lesion. Cold snare polypectomy has shown to be safe and effective for colorectal polyps up to 10 millimeters in size. It's also been shown in a couple of RCTs to be superior to cold biopsy forceps, with a higher complete resection rate and shorter polypectomy time. It's also superior to using hot biopsy forceps, and it has the added benefits of avoiding thermal injury risk, has a lower rate of incomplete resection, and improves tissue capture for histologic examination. The other benefit of cold snare polypectomy for smaller lesions is that patients can remain on anticoagulants and antiplatelets. Cold snare polypectomy is supported by a number of guidelines. The JGS guidelines recommend using cold snare polypectomy for colorectal lesions less than 10 millimeters in size. ASGE guidelines also recommend using cold snare polypectomy for sub-centimeter colorectal lesions. It also suggests for non-pedunculated lesions between 10 to 19 millimeters in size can be removed by cold snare polypectomy, with or without submucosal injection. The ESGE guidelines also support the use of cold snare polypectomy for sub-centimeter colorectal lesions. For lesions that are between 10 to 19 millimeters, the ESGE recommends hot snare polypectomy with or without a submucosal injection. However, they do also recommend that in certain situations, there may be a role for piecemeal cold snare polypectomy to reduce the risk of deep mural injury. It's well established that cold snare polypectomy can be used for colorectal polyps less than a centimetre in size. So the question then is, how far can cold snare resection go? And how do we balance up these competing interests of safety and efficacy for our resections? Or indeed, are they actually competing? And can we achieve a safe and effective resection in both the colon and the duodenum? A number of cohort studies looking at cold snare polypectomy in the colon of lesions that are 10 millimeters or larger in size have been performed. Most of these studies are retrospective in nature, with 2 prospective studies from 2018. These 2 studies were of serrated polyps. A number of other studies included a combination of adenomas, SSPs, and hyperplastic lesions. The use of submucosal injection prior to cold snare polypectomy was variable. The overall rate of post-procedural complications was low, and the residual rate at first surveillance was very similar to that seen in hot snare polypectomy cohorts. Interestingly, in the 2 prospective studies of SSPs, the residual rate was very low. The main concern held with cold EMR is the risk of an inadequate resection with a higher rate of recurrence or residual adenoma or serrated polyp at follow-up. In this study, published in Endoscopy International Open in 2021, on multivariate analysis, the predictor of recurrence after cold EMR was that of histology type, with a higher risk seen with tubular villus adenomas than tubular adenomas, SSPs, or hyperplastic polyps. Other predictors were larger polyp size and older age. On univariate analysis, the use of a clip-through during polypectomy and also race were predictors, but these did not bear out on multivariate analysis. In a recent randomized control study published in GIE, the 4 dominant techniques used for removing colorectal polyps were compared. These included cold snare polypectomy, cold EMR, hot snare, and hot EMR. 238 patients were randomized to one of these 4 techniques. It showed that cold snare polypectomy technique was the fastest, and the overall incomplete resection rate was 2.4%. However, none of these incomplete resected lesions were those performed with cold snare polypectomy. The authors concluded that cold snaring was the dominant technique for sessile colorectal lesions between 6 to 15 millimeters in size. The potential use of cold snare resection in the duodenum is particularly exciting, mainly because of the complication rate seen with hot EMR in this location. The complications are higher, both with post-procedural bleeding, intraprocedural and delayed perforation. This is partly related to the thermal effect and injury from hot EMR. The duodenum is anatomically predisposed to complications in many respects due to it being a thinner wall, relatively fixed structure, and having less mobility to allow clip closure as well. It's also a highly vascular structure. There's not yet a huge body of evidence behind using cold snare polypectomy in the duodenum. The ESGE do support its use for lesions that are less than 6 millimeters in size. The JGES has yet to put out guidelines on this, and the last ASGE guidelines from 2015 predates most of the evidence for cold snare polypectomy in the duodenum. The evidence behind cold EMR in the duodenum is looking promising, though it is still early. There are 2 comparative studies. This was published in Gut this year by Rapici and Roche. It's a retrospective study conducted at 4 tertiary centres of duodenal adenomas that were 20 millimeters or larger in size. They included consecutive patients who had cold EMR between February 2020 and June 2021. This was 33 patients, and they compared them to a retrospective group of patients who had hot EMR in a 1:3 ratio, including 101 hot EMR patients. They looked at the technical success rate, procedural time, complications, and residual at first follow-up. The technical success rate was similar between the 2 groups. Cold EMR was significantly faster than hot EMR at 48 minutes versus 97 minutes. Intraprocedural and post-procedural adverse events were not seen in the group of patients who had cold EMR and were significantly higher in those that had hot EMR. In the hot EMR group, there were 17 intraprocedural serious adverse events. This was 16.8% of the cohort. They included 13 bleeds and 4 perforations. The post-procedural adverse events were seen in 26 patients with 17 bleeds, 6 delayed perforations, 1 fever and 2 strictures. At first follow-up, there was no significant difference between the rate of residual adenoma between the 2 groups, at 12.1% in the cold EMR group and 20.8% in the hot EMR group. The second comparative study was published in GIE this year by Trivedi and Anand with colleagues. It's a retrospective study of 2 tertiary centres looking at duodenal adenomas 5 millimeters or larger in size. They included 41 who had cold snare polypectomy and 69 with hot snare polypectomy. Submucosal injection was used in some patients. The rate of intraprocedural bleeding was very similar between the 2 groups at about 10%. Delayed adverse events, however, were significantly higher in those that had hot EMR at 10% versus 0%. The overall rate of residual adenoma at first follow-up was about 26%. The predictor of residual adenoma was a larger polyp size. There was not a significant difference in the adenoma residual rate between hot and cold snare resection. In conclusions, the indications for cold snare resection are increasing. We should use it as standard for colonic adenomas up to 10 millimetres in size and serrated polyps up to 20 millimetres in size. It's likely safe and effective for larger serrated polyps as well, more than 20 millimetres in size. And if there's concern about resection margins, then using a submucosal injectate with a dye, such as methylene blue or indigo carmine, can help define the lesion, or use a foot pump to help irrigate into the submucosal space to increase the defect and help define the lesion further. It's possibly also going to be safe for lesions, colonic adenomas up to 20 millimetres and even larger in size, as long as we make sure the margins around the lesion are clear and that we're not leaving adenoma islands behind. In the duodenum, given the risk profile of bleeding and perforation with hot snare resection, there's going to be a place for cold snare resection as well. At the moment, it can be safely performed for smaller lesions, less than 6 millimetres in size, and we'll likely see a growing body of evidence for use in larger lesions too. The resection technique is important. Removing all the polypoidal tissue by snare resection is going to be essential to ensure a low rate of residual polyp at first follow-up. Surveillance is required in these patients as well, and there's a growing body of evidence that if there's residual polyp seen at first surveillance, this can be safely removed again by cold snare resection. A further advantage of cold snare resection is it may reduce the risk of overall adverse events. This leads to lower use of healthcare utilisation and lower wastage. Thank you. I hope that this lecture has shown where cold snare polypectomy is now and where it's heading in the future. I wish you the very best for the remainder of this esteemed conference, and I thank the organisers again for inviting me to talk today.
Can you hear, Bronte?
Hello?
Bronte, can you hear us?
Yes, now, okay.
Yeah,
Yes, no, we can't. I can't hear you on the computer. You're muted from my end. Okay, great. Yeah. Yeah, great question. So to try and reduce the risk of post-polypectomy bleeding with hot snare resection, we would do a clip closure of the defect to try and reduce the risk of post-polypectomy bleeding for lesions up to 4 centimetres in size. For larger lesions, it's more difficult to close and oppose the sides of the defect to reduce that risk. We don't know what the answer is after a cold snare resection. It looks at the moment that the risk of post-procedural bleeding is significantly lower. So it's probably not required in those patients unless they are have an obligate need to be on anticoagulation, and in which case I would close with clips if possible.
Okay, Bronte, another thing which we struggle with is a duodenal lesions. So what's your advice for duodenal EMR? So will you close them with a loop because the incidence of bleeding is extremely high in them? So would you close them with a clip, or would you put a loop and clip or a stitch or a suture? What's your advice?
I don't think she can hear.
Can you hear me? Yes, the audio is not going. No, she's saying there's no audio.
Hi, Yogesh.
Yeah. So what I was asking that about duodenal lesions, the large duodenal lesion which we do EMR. So what would you advise? Would you close them with a clips? Would you take a stitch? Would you put a loop and clip, or what would be your advice?
Yeah. Yeah, this is a really hot area of research at the moment to try and reduce the risk of bleeding after duodenal EMR. For hot EMR, my practice is if it's a smaller EMR, then I do try and oppose it. However, once you resect a lesion more than 2 centimeters or greater in the duodenum, it's really quite difficult to oppose the edges because it's quite a fixed structure. And so I think that the possibilities lie within topical topical hemostatic agents such as Puristat as one. And we're currently part of a multi-center study here in Melbourne looking at this. I think using a stitch closure is going to run into the same problems and potential complications as clip closure. And so really we need to start thinking about non-opposing ways. So not trying to close the defect itself, but look at other measures to try and reduce the bleeding risk in the duodenum.
So if there are no more questions, we'll wind up with this session and we'll move on to the next topic.
So moving on to the second topic of the session, which is